Historically, an intellectual disability diagnosis was treated like a finalized verdict. It acted as a strict ceiling on a child's potential, dictating exactly what they were expected to achieve. Today, the clinical reality is far more nuanced. We recognize it as intellectual developmental disorder, or IDD. It begins in childhood, and crucially, it exists on a highly variable spectrum. Moving from the idea of a fixed state to a dynamic spectrum requires a shift in how educators and clinicians approach intervention. You cannot apply a one-size-fits-all limit to a condition that looks different for every student. Recognizing this variability is the mandatory first step to facilitating a student's progress. It transforms the diagnosis from a restriction into a personalized roadmap. To map out that progress, we have to look at how IDD specifically impacts a student. The first half of that clinical impact involves the hurdles it presents to cognitive reasoning and traditional academic learning. But there is an equally critical second half to the disorder, the impact on everyday adaptive skills. These adaptive skills cover the triad of human independence, interpersonal communication, basic social judgment, and daily physical living tasks. This dual nature creates structural friction. Traditional school systems are built almost entirely to address the cognitive pillar. They are often unequipped to support deficits in daily adaptive functioning. This mismatch creates a vacuum of support. Without targeted intervention, students are left in a building focused on academics, without a framework for the most basic aspects of social navigation. Bridging that gap begins in the clinic. A licensed clinician conducts standardized behavioral assessments to provide a formal diagnosis. This formal diagnosis functions as the clinical authorization necessary to trigger specialized resources and legal protections for the student. In Georgia, a real-world blueprint for this kind of comprehensive ecosystem exists within K-12 settings through MentalSpace School. The core of their model relies on a specific operational shift. Instead of treating therapy as an external addition, they integrate dedicated, culturally diverse therapist teams directly into the school's framework. Embedding these clinicians directly into the infrastructure turns the building from a strictly academic center into an integrated healthcare ecosystem. That ecosystem operates on 3 distinct levels, starting with direct student intervention. This includes individualized education plans, or IEPs, and dedicated life skills coaching to address those adaptive deficits. Because student needs can change rapidly, the model provides same-day teletherapy to provide support before challenges escalate. The second tier focuses on environmental baseline safety. This involves implementing school-wide crisis intervention and protocols for suicide and violence prevention. Maintaining that environment also requires staff wellness programs. Educators need support to maintain the resilience required to manage highly complex classrooms. The third tier brings in the broader community. Family counseling extends the therapeutic support network beyond the school walls, ensuring strategies used in the classroom are supported at home. An intervention ecosystem only succeeds when it simultaneously fortifies the student, their environment, and their family. Many healthcare models fail because of logistical hurdles and high costs that prevent families from participating. This school-based model removes the financial barrier. Medicaid covers the cost at $0 to the family, and the program is accepted by major commercial insurance providers. All medical and educational data is integrated securely, strictly complying with both HIPAA and FERPA privacy laws to protect student information. A care ecosystem is ultimately ineffective if families cannot afford it or trust it with their privacy. When a school commits to this kind of strengths-based, dignity-first care architecture, the results are quantifiable. Data shows a direct impact on behavioral engagement, with an 89% improvement in student attendance. In terms of clinical mental health, there is a 92% reduction in anxiety levels among supported students. And regarding the broader support network, family satisfaction reaches 85%. These metrics prove the efficacy of comprehensive care. It addresses the IDD diagnosis while reducing secondary symptoms of anxiety and isolation. At the policy level, legal deadlines, like Georgia's HB 268 compliance by July 2026, are prompting schools to adopt these integrated frameworks. While legislation dictates the timeline, the measured success rates prove why these integrated models are necessary for the future of education. A diagnosis of intellectual developmental disorder establishes a baseline for a child's support structure. With the right comprehensive support system in place, that diagnosis ultimately serves as the foundation for a student's long-term independence. Progress in education requires moving past outdated expectations and building clear paths to adaptive success.